like to introduce Mr. Irfan Malik as the next speaker, but briefly I'd like to say a word. He is the spinal lead for the service, but he's also one of Europe's leading pioneers in spinal endoscopy and the management of acute spinal conditions and making sure that patients are discharged on the same day or the next day. He really has preceded the wave which we're all hearing about, which is spinal endoscopy. He published his case series over a decade ago of over 500 cases managed endoscopically, and he really is at the forefront of minimally invasive surgery, and it's a delight that he's taken up the role as the spinal lead at Fortius Clinic. No further ado, we'll pass the mic on to Mr. Malik, who'll talk to you through the fundamentals of spinal anatomy. Mr. Malik?
Thank you, Ed. It will automatically display, or I have to do that? Sorry. Right, so I'm going to talk about the anatomy and the biomechanics of the whole spine. So this is the topic when we are in the medical school, we normally takes 2 years to read about the anatomy of the spine. And then when we graduate, and if somebody wants to go into spine, it takes another 2 years to learn about the spine biomechanics. So obviously, I can't finish in 15 minutes everything. I highlight, because when we are selecting the topic, so this was the topic which we asked because just as a revision before we going to discuss our other topics in detail. So this reference will come again and again. So what is the normal posture of spine? The normal posture of the spine is if I stand still like that and with a horizontal gaze, and if somebody is looking at me from the side, so my head should be on the shoulder, shoulder should be on the pelvis, and pelvis should be on the feet. And if we have that posture, that is our normal posture of our spine. And that's how our sagittal balance is. But due to different reasons, it gets disturbed because of different pathology, age, other factors. And we are, as a whole, as a medical community, you guys and we work together to maintain that balance. So if you see by chance any scan or x-ray of a newborn baby, you will see his spine is very straight. You will not find those curvature in the spine. As the child start growing, sitting, standing, walking, these curves appear. And these curves maintain that sagittal balance. The most important are the cervical and lumbar. They change into a lordotic shape, while the thoracic remain into a kyphotic shape, and coccyx is also kyphotic. And on the top of that lies our head, and they are all interconnected. So we talk different regions. So first of all is the craniocervical region. I will briefly mention about the craniocervical junction. So the craniocervical junction is part of our spine where, with the help of this fulcrum which we call C1, the spine is connected with the head and down to the rest of the spine. So it is provide all that sort of the spinal movement which we enjoy every day, mainly happen at the craniocervical junction. And with that sort of mobility, because at occiput to C1, we enjoy the maximum flexion. From C1 to C2, we enjoy maximum rotation. And that all comes at the expense of our ligaments and the muscle which we have there. If these muscle or ligament become incompetent, we'll not be able to hold the head on the spine. And the most important ligament which we have is called tectolial membrane and alar and apical ligament. They keep the head connected with the neck. And that's why we maintain our head movement and all that sort of flexion, extension, and rotation movement. So if we see here on these pictures, what I did here. There's no. All right, okay, we can see here on these X-rays that the C1, which has no body, no centrum, it has only lateral masses. It is connected with the top of the head, which we call the occiput, and they form a joint there. And similarly, we have a joint at C1 and C2 as well. And they are all connected. If you look on the MRI scan, these are the ligaments which connect the neck with the head. And if due to any reason these ligaments become incompetent, then we fix it surgically. And the most common cause is not generally degeneration at this level, but is it trauma, or if somebody has got an inflammatory condition like rheumatoid arthritis, and if C1, C2 junction become incompetent, there's a way of dealing it. We put our screws on the front, which we call transodontoid screw, or sometimes we fix the back of the head with the back of neck. Now I will move on to main mover of our body. So the main mover which maintains our mobility are the intervertebral disc, facet joint, muscle, and ligaments in the subaxial spine level. So if we see here, that is we define the spine as a functional motion segment. We don't never talk about the individual disc or individual facet or the level. We always talk about a segment. And the segment of the spine consists of two vertebral bodies with intervening disc. And on the back, we have a facet joint. So in between, there is a spinal canal. So maximum brunt of our activity when axial load our spine goes through the interior column, which is the vertebral body and the disc. And the disc is made up of two material. One is annular fibrosis and other is nucleal pulposus. So the nucleal pulposus is the inner core. And when any weight come on that, it equally damp and equally distribute in the spine. And that's how normally it works. And it has a quality that it imbibes the water because it's a proteoglycan. It has a micromolecule which imbibes the water. So if we see here, there is a nuclear pulposus in the middle, annular fibrosis on the sides, and above and below, and they are connected to the end plates of the vertebral bodies. And when we born, our disc has a blood supply. But up till when we reach to 30, the disc has no blood supply. It has a zero blood supply. So where disc get its nutrients and where it takes the waste away, so there's a semi-permeable membrane which causes the diffusion. So through the diffusion method, water is imbibed and water is released. And when the water imbibes, it brings the good nutrients with that, and when water releases, it takes the waste away. So normally there is a very narrow balance between extradiscal and intradiscal oncotic pressure. So when the weight comes on the spine, it allows the water to release. So when we wake up in the morning, because we are sleeping overnight, it imbibes all the water, we are taller. The whole day we work, we start losing our height. Disc form the 20% height of our spine. So during daytime, when the water leaks out due to constant loading, we are shorter in size. So there is a narrow balance between extradistal and inter. So when we load the spine, the water leaks out. It increases the oncotic pressure because of the protein. And then the protein absorbs the water. That's how we maintain our balance. And at certain stage in our life, as we degenerate due to constant loading, or if there is any eccentric weight come, our nuclear pulposes start degenerating. And when the nuclear pulposes start degenerating, it cannot actually carry the proper weight distribution on front, back, or side to side. So if, as I said, that because of this intradiscal pressure, which is the oncotic pressure, plus the pressure of our body weight, which we call the hydrostatic pressure, they are in equilibrium. And if that change, that will cause the trouble. And if we are constantly pressure on the spine, obviously the spine at the disc will start degenerating. And that's where the problem starts. So normally when you guys use a lot of traction treatment, and that is the main principle behind traction treatment. Because when you guys give the traction, what you want to do? You are actually pulling the disc away and reducing the intradiscal pressure. You are reducing the hydrostatic pressure. And when the hydrostatic pressure will release, this means more water can come in. And when the more water can come in, that will help in disc repairing itself. And that's how the traction treatment works. Second, activity. If we are doing more activity, this means when we're standing, the water is going out. When we are lying down or doing activity, water is coming in. It increase and decrease the pressure inside the disc. And that's why the activity always helps. If we are moving around, we're doing physical activity, because of moving the water in and out, it helps. If we don't do that activity, if somebody always have a sedentary lifestyle, he can't enjoy that movement. That means that not a lot of water is coming in or out, and what it will affect, this means that not healthy nutrients are coming in, not the waste is going out, so disc will start degenerating more and more and will cause more trouble. Second problem is the eccentric weight, which I will show in my next slide. So normally if the load goes axial is fine. When we have a bad postures, we go to the eccentric weight. The weight is more on one side, and that side will cause problem. If you think about the cervical spine for a moment, or lumbar spine, so if somebody is, rather than weight going here, if it start going more on the front, because it's tilted like that, if more goes weight on the front, then what it will happen? It will cause more changes with not only with the nuclear pulposes, but the annular fibrosis as well, and it start bulging out. And when the annular fibrosis bulge out, the periosteum of the vertebral body also bulge out with that, and that lead to the formation of osteophyte. That's how the annular fibrosis is. The normal annular fibrosis, the outer coat, is nicely threaded, crisscross, and it maintains the stability of spine. And especially in the lumbar spine, because they are oriented at a 30 degree as respect to the disc space, that doesn't allow it to cause rotational or torsion movement. But with time, when the nuclear pulposus goes off, this start degenerating with age. It lead to laxity of annular fibrosis, and that's where the deformation of the spine starts. So that's normally, if we see here, the manual workers who's wandering up or down, which is the correct position, because position which is below, he's away from his vertebral body. He's increasing the angle of axis of rotation, and he's in the more trouble to cause the pain and damage the spine than one on the, which is keeping everything close to our body. So normally when we are lying in the bed, there's no weight on the spine. When we are sitting, weight on the spine is 500 Newton. When we are standing or mobilizing, it's 250 Newton. So it's half when we are standing and moving. It's become double when we are sitting. And when we are doing that sort of movement and bending completely forward without bending the knee and the hip, the weight on spine goes to 2000 Newton. And that is the most common cause of causing the disc prolapse or disc damage or early disc degeneration. Similarly, the gentleman who is sitting there, his eyes are facing directly to the computer screen. If he sits low and bend forward, as I was suggesting, all the forces will change and will go through the area where there is a maximum annular fibrillation disc on the back because it's a lordotic spine. So it causes bulging of the annular fibrosis and then subsequently form the osteophyte, which start encroaching on the cervical spine and also on the oncovertebral joint, and can become asymptomatic by pressing on the nerves. Another important thing, I know my time is finished. I will talk about this and then I will leave after that. It's a long topic. I have a lot of slides, but we just want to show. So the second thing which bound the spine is the ligaments. The ligaments play a very important role. And thing which I want to emphasize, which is important from physio point of view, so there's the center of the weight through which is going, where you see dotted line, which shows all weight passes through that, which is called interstaneous axis of rotation. And anything which is away from the interstaneous of axis of rotation is more important, it's more contributory rather than what is close to that. On the front of the spine, it's always we call anterior longitudinal ligament. On the back, we call posterior longitudinal ligament. Then between the spinous process, we have an interspinous ligament. So if we see from that interstaneous of axis of rotation, the posterior longitudinal ligament is more closer, about 1/3, and 2/3 is the interior longitudinal ligament. So this means the thing which prevents the extension and prevent from the damage is the interior longitudinal ligament, because that is away from the interstaneous of axis of rotation. That creates a longer moment arm, longer lever. Similarly, interspinous ligament prevent us from the flexion because it is much away from that interstaneous. You see how much is the angle, how much is the distance. So the lever is very far from the actually center of rotation. So that's why these ligaments are. Similarly, when we are doing any exercise on the muscle, we see here these abdominal muscle play a very important role. Although we say it's a front, it's not directly attached to the spine, but if we keep the last picture in mind, they are far from our spine. They create a longer lever. So whenever you guys are doing a core strengthening exercises, so these muscles must be included, and they are very vital muscle for that reason. I was keen to talk about the facet as well. So there are cervical facet, thoracic facet, and the lumbar facet. They are differently orientated. The cervical facet has a coronal orientation, so that's why they allow us a lot of movement. And the lumbar facet are more sagittally oriented, that doesn't allow the rotation, that allow only the flexion extension. The thoracic spine doesn't move much because it is supported by the rib cage. There are costovertebral joint, and on the front that is sternum. So that protects the thoracic spine. That's why we get the less thoracic injury as compared to cervical or the lumbar spine. So this is when there is a cervical spondylosis happens. Once we start aging, so spine thinks, body thinks that it's destabilizing, and it will try to restabilize that. And these restabilizers we call cervical spondylosis, where because the disc lost the height, it become more stiffer, come closer together to look after itself. Second, if I'm standing on some top surface, on a narrow surface, I wobble. If a surface is broader, I will not wobble. So that's why the cervical spine forms loss of osteophyte. It is trying to restabilize itself, so it looks stronger. Similarly, the ligaments, especially ligament of flavum and other ligaments, become thicker in the body. They are trying to protect. So that's how the process of spondylosis starts. Although these structures are trying to restabilize and helping the spine, but actually they start narrowing the spine, they cause wear and tear changes, degeneration, and they are quite sometimes painful. So I think the next is the topic was the pelvic tilt and indices. I will stop here and will allow the next speaker to come, please. Thank you.
Thank you, Mr. Malik, for that incredible whistle-stop tour of anatomy and biomechanics. It was certainly worth overrunning. I learned lots from that myself, and I'm sure the audience did. A bit like the TFL theme for the day, and like buses, we now have 2 pointers, so the speakers won't have issues pointing, and I do apologise for that. The next speaker is literally a giant in the field of robotics, AI, spinal innovation, and I'm honoured to share no less than at least 5 papers with him as a senior co-author in the last decade or so. I won't take up any more of your time. Gordon Gravovac.
Thank you. Let me try to find my lecture now. So, regarding the height from day to night, I vary about an inch because I'm 6'7". So every day, now I'm aging, so the variation is a little bit smaller. So it means my discs are not so well hydrated. I'll talk about a little bit about a field of the problem which affects the cervical spine, and I will try to talk about, especially about the cervical radiculopathy on the first part, and then on the second part will be the cervical myelopathy, which I really love. So what is the cervical radiculopathy? Well, that's the most commonly used cause by the soft discs. And when I say the soft discs, that's usually self-limiting disease in vast majority of the cases if it doesn't cause a significant neurological problem or horrible pain. Foraminal stenosis is the second most common, and that's evidence, and that's a consequence of the aging process. And the most important is to recognize them at the beginning and start appropriate treatment. As you can see, the peak prevalence of cervical radiculopathy is usually in the mid-50s. Most commonly is affected the C7 nerve root, and usually the typical time when people need to think that something needs to be done is within 4 to 8 weeks on average, because in vast majority of the cases, symptoms starts getting significantly better in that early stages. Why C7? Just because of the biomechanics. The neck is much more wearing off on the lower levels, as the same happens in the lumbar spine. So, clinical concept, cervical radiculopathy is usually followed by the pain, neurological dysfunction if there's a significant compression of the nerve root, and also a patient will usually have unilateral radicular pain. Occasionally it can happen on the both sides, but that's usually it's a really complicated case. What is the most important for us, and also you as a practitioner, to find the pain pattern, because it will tell you exactly where it's in neurology in vast majority of the cases. Is there any kind of sensory change? What is actually the power of the muscle that has been affected? And we also need to distinguish if there's any kind of component of the spinal cord dysfunction, because that can overlap. Soft disc can cause also the core compression on the top of the nerve root compression. So annual incidence, it's more common in the males, probably about, I would say, 100% more. It's about 100 patients per year, and in the women is a little bit less. And as you can see, the frequency starts most commonly on the bottom of the spine and then starts raising up. It's quite uncommon to see soft disc herniations higher in the spine, especially around the C2, C3 level. The difference between the soft disc herniations, vast majority on the C5, C6, C6, C7, and it's two components, mechanical and chemical component of radiculopathy. Thankfully, how the spine has been set up and it actually anatomy, the disc has the tendency to herniate it on the sides. Our body wants to protect the spinal cord. It's rather that it will sacrifice the nerve root rather than the spinal cord, and thankfully the disc always herniates out toward the foramen. If it goes into the purely in the foramen, it can be extremely, extremely painful, and these patients may not respond on the conservative management. Foraminal stenosis, that is usually a chronic condition. People will present with the symptoms, which last for several episodes during the lifetime. They will come and go, things will resolve, etc. But eventually it may lead to something more permanent symptoms when they will need a surgical, probably, intervention. How it's recognized? It's always through the good clinical history, and us speak with the patient. What makes the pain worse? Where is the pain localized? How you can provoke, what will alleviate the pain, etc. We can make the provocative test. Provocative test is, I would say, historical from anatomy when we didn't have the MRIs or CTs, but also it's extremely important to look to the upper extremities. Is there any kind of problem with shoulder? Because I see lots of patients which come in my clinic, they think they have a cervical radiculopathy or due to foraminal stenosis, but they have a shoulder problem, which is much more common. So that needs to be ruled out quite frankly, really, during a clinical testing. Carpal tunnel, quite frequently common. Ulnar tunnel nerve compression also can cause the problem, but that's the reason why we will reach to the certain, I would say, investigation, For example, first of all, the choice will be the MRI. If we have any kind of clinical coincidence, we can look to the other, like a shoulder to roll. There's no any kind of underlying wear and tear change. And electrodiagnostic will actually help us to maybe delineate if there's any kind of acute radical component. Red flags, always look when you have a patient with a cervical problem, any kind of red flags. Clumsiness in the arms, gait disturbances, brisk reflexes, because you want to rule out my next part of the topic, which is cervical myelopathy, which can cause a devastating problem for the patients. Also, clinical history, it's quite important. Does the patient has a fever, has any kind of history of the cancer, etc. Conservative management is our preferred, which you all know very well, and that you lead this you do it very well. NSAIDs and opioids are a short-term fix and can lead to the removal of the chemical component of the pain. Epidural steroids are reserved for the patients who have a severe debilitating pain that cannot participate in the physiotherapy, and the surgical options are reserved for the patients who are completely resilient to any kind of conservative management, or if they have a profound neurological deficit. What we actually can do, well, we can do the anterior approaches, posterior approaches, depends about the anatomy and where the compression is. Preference is that you can do the fusion, which has been the standard case since the long time, since the, I would say, after the Second World War, when they have started the anterior approach to the neck. But the first successful approach for treating cervical radiculopathy was posterior femorotomy. The paper has been published in GNS, and actually the surgeon said this was the best surgery in the neurosurgery we can provide for our patients, because they give such a good pain relief. In the modern time, we can use lots of cervical disc arthroplasty, especially in the patients who have a younger spine. Doesn't matter so much the age. It's about how the spine looks like. If the spine, we all age differently. Now everything is modern, everybody longevity, how our skin looks like, but also our spine changes, I would say, ages completely differently. So what are my messages? I would say this is usually self-limiting disease. In vast majority of the cases, which is about 90% of the cases, patients will substantially recover through the course of usually 3 to 6 months, and that period can be on the conservative management to maintain it for at least 2 to 3 years. Repeat examination, we'll need to do the MRI if we suspect of the core damage or the patient has a profound neurological deficit. Then I will not wait for 4 to 6 weeks to image the patients. Do not overtest the patients too early. I know we treat sometimes with anxiety with MRI because the patients puts the pressure on all of us. But I think if you have it, then we all treat the picture, not the clinical symptoms. Watch out for myelopathy, because that's something which is really, really important to find out earlier at the beginning, because if it starts progressing, we cannot sometimes reverse the neurological damage. And it's extremely important to document the distribution of the pattern of the pain, because that will help us to make the diagnosis. Is this wear and tear change, especially in the cervical foraminotomy, is this really causing the problem? Because the cervical foraminotomy, foraminal stenosis, is quite common, prevalence is quite high, but is it really symptomatic? We need to rule out, make sure if we subject the patients to the surgical intervention that he actually benefits from it. So this is the common case when we treat the patient with the cervical problems. We would like to pick up the cases when they will, actually the compression of the nerve, which is so severe that it founds out more rapid neurological deterioration. If the pain is sometimes the patient's neurological examination can be obscure with a good amount of the pain, so that pain needs to be well managed. Sometimes it's good to try to give the steroid injections, try to cool off the pain and make the things much manageable. And I always tell the patients, if it's treat the pain at the moment for you in acute phase, you need to go back to the physiotherapist, because this will be treated in more than 90% of the cases conservatively. So even though the prevalence is high, from 107 in the males, less than 10% needs maybe some intervention. Good. Now I will give another talk which overlaps. Am I on time? Good. I try to catch up that because I like to talk quite fast. So myelopathy, I like myelopathy because it's much more easier to make the indication for operation. What is the reason? The reason, if you have a spinal cord damage, there's no discussion about conservative management. So it's more surgical disease. And I will catch up a little bit later. Not every cervical myelopathy is a surgical indication, especially in the early stage. So on average, we have at least 2 years delay in the diagnosis. That tells you it's quite commonly unrecognized. Typically affects more elderly population, more than age of 50. And MRI will be the choice of the preference for diagnosing, because we need to see what is happening with the spinal cord. We can diagnose the spinal cord compression with the CT, with the CT myelogram, but what is happening and how much big the damage in the spinal cord, only the MRI will tell us. So the core concept is that actually the spinal cord dysfunction. Spinal cord dysfunction can happen in the cervical spine, but also can happen in thoracic spine. Cervical and thoracic myelopathy can overlap, and it's quite crucial to examine the patient properly and maybe to investigate the whole spine to see where the problem originates, especially if the patient presents more with the lower limb symptoms. It's the most common reason for a patient to develop spinal cord damage in the modern world. Many people have heard more talk about multiple sclerosis because it affects much more younger population, because it devastates the people when they're in the younger age. But when somebody is devastated at the age of 70 or 80, this population cannot speak up. So that's the reason we as a surgeon, as a practitioners, we need to speak up. This is the most common reason that patients end with the spinal cord damage, which is a big socioeconomic burden on the whole system. What is the reason? What is the pathology? Pathology can be the static compression, which can be from the soft disc, which is quite rare. It affects more commonly younger population. The second one will be from the osteophytes, because even though when we start aging, our vertebral bodies will expand, will grow, because they will try to increase the width to share the load. Some people have a congenital stenosis. Trust me, in my case, I have done my MRI. I have a canal, huge, wide. My osteophytes can grow for many years. Ossifications of the ligament, that's called OPLL. We have been all learning about OPLL, that it affects more Asian, like Far East, like Japan, etc. Trust me, in London, in the UK, it affects everybody. We see lots of patients with OPLL. That's a really nasty disease, which actually is quite progressive. It can cause really debilitating problems. Dynamic injury usually will happen if the patient has sustained some kind of instability due to the rheumatism or inflammatory spondyloarthropathy, or any kind of, trauma. Clinical effect, well, it will have you have upper and lower motor signs, and I will not go depending about where the level is of the compression. Incidence, it's significantly less than the radiculopathy. It's only 41. That's a North American study. The whole problem is that in the UK, it has been treated prevalence is really low, but obviously we are not picking everybody, because the problem is sometimes the people will complain about the numb hand only, or a neck pain, which is like a mild symptom of myelopathy. So probably the prevalence is much higher. And in the primary care practice, usually starts affecting people of age of 64. People are quite affected, people with the mucopolysaccharidosis, people with a short posture, narrow congenital spinal canal, they will develop earlier myelopathy, and usually the symptoms are going to be quite more severe. So degenerative spondylosis is the most common. Dynamic compression is the least common. Ligament hypertrophy will happen more in the age population, like it's happening for spinal canal stenosis in the lumbar spine, which you need to know. 1 in 5 patients with lumbar canal stenosis may have problem in the cervical spine, which is quite common. It's like 20%. Congenital stenosis, people with dwarfism, that's quite common, but you will not operate easily the patients with the dwarfism. What is the reason? The reason is that in the vast majority of cases, they are quite asymptomatic. It's quite difficult to treat them. I have treated the kids in the States, and it will need to be really carefully considered patients with a small posture, especially the kids, when you will actually start operating, because they will need more operations down the line. But there are many different diseases which can mimic the myelopathy, which is like B12 deficiency, a copper deficiency, and that needs to be ruled out depending where the signal is in the spinal cord, because the treatment may be different, and you may treat the patient for suspected myelopathy, and the patient doesn't respond, and it actually progresses afterwards because you haven't picked up the right thing. Have I found a patient with ALS in my clinic which has been suspected for myelopathy? Yes, I have. Thankfully, not many. That's a horrible disease. So this picture will actually tell you roughly where the problem may sit. The pathology can sit from the front or the back of the spine. It can cause the inflammation, it can cause the core compression, etc. The problem starts when the cord is affected, when it causes the cavitation in the spinal cord, because there's no return back. What we think, in the vast majority of cases, we can stop the degeneration, further the damage of the spinal cord, but when the patient loses something, you will not get back. Not 100% true, but with the great support, I can't advise the patient. I cannot say which patient will improve to what extent. And of course, if you're treating somebody who is 85, it's not the same as you treat somebody who is 65, because I would say, plasticity of the whole body is completely different. They don't have compensatory mechanism. So how it's recognized? People will complain usually with a stiff neck, numbness in the both hands, or will say, I have a numbness in the lower limbs. I will start losing the problem with the buttoning. Now nobody writes, everybody types, so you ask them if they have a problem with the typing on the phone. Gait imbalance, especially if they're walking during the nighttime. When they close the eyes, nobody will close the eyes, but when you close the eyes, you lose the compensatory mechanism of the vision. So that will significantly increase the incidence of the falls. Second of all, if the symptoms are rather persistent, transient, and in the last options, if you look like urinary or bowel dysfunction that comes at the end, we don't want the patients on that end. Yes, clinical examination is the cornerstone. MRI will confirm, but the whole point that we don't want to miss it at early stage. So, red flags is always rapid neurological progression. Don't feel free to refer the patient for a surgical advice or opinion, because that disease can progress and can progress quite frequently, especially if the patient has a fall or a whiplash injury in the car. Second of all, as I told you, myelography is an option for the patients who can't have the MRI, but I can talk about that in the American Association of Radiology. In the paper, they scan everything. Americans are a little bit more relaxed. But severity of the clinical picture doesn't depend about the MRI finding. Sometimes the patients have much more severe picture with no radiographic compression, then you need to look for instability. That is a crucial thing. That's the reason you need to send to the people who do a lot of those cases, because they have I would say, when they look through the scans, they can immediately have a hunch where the problem will sit. Conservative management is suitable for the patients with the mild symptoms. What are the mild symptoms? Just numbness in the hands or neck ache. But they need to have a good, I would say, advice. Advice is that they should abstain from any kind of contact sports. No rugby, no boxing, no contact sport, kickboxing, that's forbidden. Roller coaster, bungee jumping, not at all. Because that's the problem. Or I had a patient who asked me, can he drive, the small cart on the, I said, no. What is the reason? That small cart that even drive faster than the Formula One. So the problem is that if you have a mild symptoms, estimation that you can deteriorate is about 50% in the next 5 years, roughly. A little bit less, a little bit more, depending on the studies, what you're looking. Recommendations for the operations if the patients are suffering from moderate to the severe or rapidly progressive myelopathy. That's not for conservative management at all. Primary aim is to decompress the spinal cord, and that can be changed, and what type of the decompression, depending about localization of the problem, if you remember my picture from before, and actually to advise the patient that they'll have some kind of residual problems down the line. Why this is important? Because this patient have a spinal cord damage. They have I would say like a stroke in the brain. You will develop more rapid deterioration due to degeneration. And that message is never led to the patients. And they will always ask, but I'm getting much quicker worse, even though I'm like in the 70s. I look like I'm an 85 or 95. My neurological deterioration is progressing. Yes, because you sustain the spinal cord damage early in the life. So it's quite important if you have somebody who is like in the 20s, 30s, or 40s, or any patient with a spinal cord injury. So think it early. Delay can harm the patients. Look for upper motor signs. Mild disease can be monitored and reviewed closely with a good advice. MRI will tell us where the problem sits. And document the baseline, because the baseline, sometimes the patients and the neurological examination will tell you how rapidly the patients are progressing, especially if you see them after 6 months or a year. So, this is my take-home message. And I will stop it here. Thank you very much for listening to me. I tried to cover in the 30 minutes. I was on time. And I will leave to Ahmed for our next speaker.
Thank you, Gordon, for more than keeping to time and for giving us an extremely thorough pre-say of everything related to the neck. Just some few housekeeping notes that I've been given by Ed. We're actually recording all of these talks. All the slides are available to share. All the videos are available to share. If you're desperate to take a photo of a slide, please do. But just enjoy the meeting and watch the show. And at the end of the sessions, you will get an email link that will have an outline of all the slides and talks. Now, as spinal surgeons, we have this false perception that we've got great vision. In reality, all we're doing is squinting at shadows most of the time, and it's only until the neuroradiologist tells us exactly what's going on we're actually able to execute what we need to do. I'm delighted to introduce Dr. Naomi Sibtain, a very senior neuroradiologist with an extremely high volume practice at King's College London, who's probably one of the leading lights in neuroradiology. She's central to our MDT and reports for us at the Fortius Clinic and really guides our scalpels and drills to make sure we get the best possible outcomes. Naomi, over to you.
Thank you very much. That's a very kind introduction. You can hear me all right, I hope. I'm just going to move forward. Great. So my talk is about what to image and when. And it is quite a big topic, so it's quite a challenge to cover this in 15 minutes. But I'll do my best. There is a lot of information on some of these slides, so I'm glad that you're getting a copy at the end, which you can peruse later. So the contents of my talk are really in two sections. I'm firstly going to talk about the main imaging modalities. I'll touch on the physics very briefly and the pros and cons of each of those modalities. So we're going to look at X-ray, CT, and MRI. That's what we're going to focus on. And then I'll move on to maybe more specific clinical scenarios, look at the NICE guidelines, which are in fact very helpful at guiding us as to what the right imaging is to do and when. So first of all, the very basic and fundamental form of imaging, the X-ray, which we see far less of nowadays. Well, how is it produced? It's through the electrons that are fired at a metal target. They hit the metal, and that releases energy. So I'm just trying to find a pointer. And as they hit that metal target, that releases energy in the form of X-rays, which is on the ionizing end of the radiation spectrum, it's part of the electromagnetic spectrum. And what happens is that these X-rays are what we call attenuated, which means blocked effectively by the tissues of the body, depending on the density of that tissue. So if you have bone, for example, which is very dense, then less of that X-ray is going to reach the detector on the other side, which is sitting here. So that is what we're seeing, and hence the bone being white and air being very dark. It is a very basic way of looking at the spine, as you can imagine. It's a 2D flat projected image of 3D anatomy. However, it is very quick, as you know. It's cheap, it's very easy. There is very little ionizing radiation. There is some bone information, but not much else, really. So very limited for soft tissue, very poor sensitivity for early infective processes, which I would emphasize, fractures, which we'll look at, and neoplastic processes as well. And just to show you in terms of fractures, just some percentages of detection, the comparison compared to CT is substantially low. So just doing an X-ray thinking you're going to exclude a fracture is quite misleading. But here are some examples of their uses. So one is looking at the overall alignment of the spine, which is quite useful in terms of surgical assessment as well. So in this patient with a scoliosis, you can see very clearly and get an overall picture. As Gordon talked about, instability is really important. We don't get that dynamic information on CT or MRI, but a very simple lateral flexion and extension X-ray will tell us whether there is movement going on at a particular level, which is really important to know. And although I've sort of put it down in terms of fractures, in the context of osteoporosis, it can actually be quite helpful just as a sort of screening tool to see if there are compression fractures that might be the source of the patient's pain. Other examples are, from a surgical perspective, it's a good screening tool preoperatively and postoperatively just to have a crude assessment of how the metalwork looks. And other conditions, so this is an example of ankylosing spondylitis, where you can see some syndesmophyte formation and fusion of the sacroiliac joints bilaterally in someone with ankylosing spondylitis. So CT is the next step up from an X-ray quite substantially. So it's still using X-rays, but the way that they are used is different. So they're in the form of this tube. It's a bit like a polo mint that you can see in this picture here. And maybe some of us have had CTs in this room, so we know what it's like. There's an X-ray tube on one end, and you can see the detector on the other, and that spins around as the patient goes through the machine. So you therefore get, instead of this very basic two-dimensional view, you're going to get a whole volume of information, which is a lot more helpful. And you can manipulate that information in different ways. And to remember that this is in the form of X-ray, so what I mentioned before about tissue density, and that's reflected in the Hounsfield unit, which is then translated into a shade of grey, will give us that information. Now in the spine, it's absolutely brilliant for looking at bone. It is not so good at looking at tissue. So here, for example, I've just shown how we might look at a spine, for example, on a PAC system, where you can see it in different planes. You can adjust the plane of how we look at all these images, and you get very good bone detail. You can see how all of the soft tissues are one slight blurry grey mass, really. So you don't get that information, whereas with MRI you do. You can create these beautiful volume rendered images as well. So I've sort of talked already to tell you how good the bony detail is. It is therefore very sensitive for fracture detection, and as I've already talked about, how X-rays can be misleadingly or falsely normal when there are actually fractures present. It's incredibly useful from the surgeon point of view, so looking at the integrity, what do the pedicles look like if they're going to place screws there, gives them 3D volumetric information. Post-surgically, it gives a lot more information on positioning of screws and so on. It also might give a sort of useful adjunct if you're assessing foramina, for example, to see whether there's any bony extension into the foramina. It's not just soft tissue, it can be osteophytes going in. And if you do the two studies side by side, that gives the surgeon a bit more information as well. There is the con, and maybe patients ask you about this, of ionizing radiation. So you do have to be aware, just to put you in perspective with this, the lifetime cancer risk is about 45%. And then CT adds a very small risk, and obviously that will change depending on how old the patient is. So these are just some other examples of its use. On this plain X-ray, we can clearly see an anterolisthesis. It's quite hard to see the pars defect, but we can see it very clearly on the CT. This is the MRI in the same patient, where you can see a disc protrusion extending into the foramen. You've lost the fat around the nerve here, and it's contacting that nerve. But also the CT is just showing us a little bit of osteophyte formation as well. So it just gives that extra information. Here we're getting a lot more detail in terms of surgical instrumentation positioning. So for the surgeons, it's extremely helpful. This is just an example of a very subtle fracture involving the inferior articular facet of the C3 vertebra. You can see it on these reformats. But you can see how subtle these fractures can be, and they would be very difficult to pick up on a plain X-ray. This is just an example where one might or misinterpret a plain X-ray as thinking there's a compression fracture there, where we see this depression of the superior endoplates, when in fact this fracture here, for example, is involving the posterior cortex of the vertebral body, a little bit of bony retropulsion, which is quite hard to see on the CT, and that would really be classified as a burst fracture, not just a compression fracture. So just getting that more detail with fractures. Again, another example, quite hard for a radiologist to pick up on this very faint lucent line here with all the overriding bowel. But the CT can show these sacral insufficiency fractures very clearly, and it's very obvious on the MRI where there's a lot of edema. I think here I just wanted to show you, so I mean, just to give you a glance of an MRI, where we can see a disc protrusion, and although we've talked about the fact that soft tissue is not that great, actually, even without doing a CT myelogram, you can still see some soft tissue if you adjust the windows and manipulate the images. Again, we can see this disc protrusion here that we can also see on the MRI. So MRI physics, obviously extremely heavy going. I'll try and summarize in 30 seconds. So effectively, it's a very strong magnet. Our bodies are made up largely of water. Water contains hydrogen protons. These hydrogen protons will be forced to align in one direction of the magnetic field. A radiofrequency current is applied at 90 degrees. The protons will spin out of equilibrium. That is then turned off, and they'll start to recover back into that alignment. And it's the time taken for that realignment to occur that will give us some information. So that time and the amount of energy released also will vary according to the different tissues. And that is how we get the information. And that energy, or what we call signal, is translated into a shade of grey on the image. We can then manipulate the timing and sequence of those radiofrequency pulses to create different sequences, what we call T1, T2, stir. And it's a bit like bits of a puzzle. You sort of have one bit of information here, another on that sequence, and we put all that information together to get a better sort of pathological idea of what's going on. So exquisite soft tissue detail. And coming on to sort of back pain, we can look at all the various potential pain generators. So we can look at the discs, the bone marrow, ligaments, nerve roots, spinal cord. We can look at the muscle. But of course there are cons. So there's claustrophobia, patient safety, contraindications with that. It does take longer. It's not great at looking bone, which is where we talk about doing a CT as an adjunctive investigation. And then there are artifacts which can cause problems. So this is just an example. And Irfan talked about the nucleus pulposus, and this is quite a nice example of an acute disc extrusion where the signal is quite bright on T2 because there's more water content within that nucleus pulposus. And you can see how it's compressing. This is the right S1 nerve root, and you can see how the left is markedly displaced posteriorly by that disc. So it's very easy to see. Just to show you what else we can see, the facet joints very clearly. Sometimes you might pick up on facet joint inflammation due to degenerative change. That's quite a common cause of back pain that we see on scans. We can look at the muscles if there's any signal change in them as well. So I'll fleetingly go through this. It's really just to show you that there are some very good guidelines from NICE that guide you through when we should image and at what time we should image. So that goes through in quite detail about what questions should be asked at the consultation. And the key checklist really is for those red flags or situations where we might want to think about doing an MRI sooner than later. So I know we've raised this already, but some are red flags, so history of cancer, weight loss, and so on. All this slide tells you is really the fact that the vast majority of back pain that you will see, presumably, is this non-specific back pain, and that category of red flags is much smaller. This is probably another key slide I want you to observe, and again, Gordon touched on this, is that you get our reports and they're filled with all these different descriptions and dehydrated discs and all sorts, but actually a huge number of the population have these without even knowing about them, and it's really putting it into clinical context. So, as we've mentioned, just initially for imaging of straightforward low back pain without any radiculopathy, you would not want to image routinely, initially at least. But if symptoms persist or become worsening after 3 to 4 weeks, or they get worsening symptoms, then it's time maybe to refer them to a specialist. And then they may go on to have some imaging there. Very good information from GERFT, Getting It Right First Time, about there's a really good interactive pathway you can use to assess for cauda-equina syndrome. I think this has really improved the process of diagnosis and imaging. I won't go through these now, but you'll have this obviously. This is just an example of someone with a disc extrusion causing marked cauda-equina compression. You can see very normal looking spinal canal here, and this huge disc that is literally compressing that theca to next to nothing. So situations where you're going to refer on are really patients. So in the context of low back pain with sciatica, if the symptoms worsening, recur, persist for more than a few weeks, you can see the list there. If obviously they have a progressive neurological deficit, then you want to get an MRI. Similarly with neck pain, you may wait and have more of a conservative approach, and then if they have persisting signs, they'll then be referred and have an MRI. I'll touch on this very briefly. It's just a very good system that is available. It's on NICE, on the Canadian C-spine guidelines in terms of imaging. In the acute setting, it's normally that patients will end up having a CT. I'll fly through this because it's obvious. I'll just show you quite a sort of an interesting case where this patient initially had some plain x-rays. They were quite a difficult historian. They had some pain. And so the plain x-rays were reported as normal. You can see that for yourself. Then they went on and had an MRI, and I'm not quite sure why. Maybe they had persisting back pain. This was done at an external hospital. And this was a very limited MRI. There was some signal change in the disc. There was a little bit of end plate signal abnormality. This was misinterpreted by the radiologist as being degenerative change, and it can look very similar. And there were very limited sequences, but actually this turned out to then, this is a few months later, I think in June, they had a repeat MRI, and you can really see how that infection has evolved over time. So you've got this very misleading normal plain x-ray to that, and that's why looking at those red flags and really asking yourself, is there anything more serious going on, to expedite that MRI sooner than later. So I hope that was helpful. Look forward to any questions, and yeah, thank you.
Thank you, Naomi, for that incredibly image-rich, knowledge-rich talk. Our next speaker I had the delight of training with on the South Coast over a decade ago, and it's been incredible watching his journey over the last decade. He's now the lead of his unit at Croydon University Hospital. He is an exceptional educator, having won numerous awards in the region for educating future surgeons and future doctors. And he also specialises in the management of spinal sports conditions. Mr. Wais Ahmed.
Thank you, Ahmed. And I'd like to thank the Fortius group for this, as well as Irfan. So today I'll be talking about the lumbar spinal disorders. I think this contributes to the bulk of the spinal problems. It's quite a vast topic, so I'll try to focus on things which are quite common to our day-to-day practice. So in terms of, I've broken it down into two parts. One is simple spinal pathology, like problems with the disc, facet joints, stenosis, spondylolisthesis, lumbar canal stenosis, and there is some more complex spinal pathology like fractures, cervical myelopathy, cauda-equina syndrome, and any red flags associated with it. In terms of the back pain, we have two different categories. One is the mechanical symptoms, which is due to the nociceptive back pain. This is normally due to injuries. And the somatic pain, which normally comes from facet joints, from the any kind of musculoskeletal components, and these are classified as the mechanical symptoms. And then we have the compressive pathology, which is the radicular pain due to compression of nerve roots. And radiculopathy is more to do with damage to the nerves, causing weakness, numbness, or any kind of neuropathic symptoms. Here, the example of a healthy disc, as Irfan has mentioned, this well hydrated, and when you compare this with the lumbar spine. In the upper lumbar spine, there is well-maintained disc height, fluid in the disc, and that's a sign of a healthy disc. But as you come down lower, you have the degeneration happening with dehydration occurring in the disc with protrusion, and there is some modic changes that is due to the leak of the disc material into the end plates causing back pain. Here again, there is this example of an healthy disc, nerve roots. You can see them quite clearly. The resolution is pretty good. This is the posterior aspect, and this is the anterior aspect, nerve roots coming out to the sides. But as the disc starts to degenerate, you start to get these cracks in the end plates, and then the disc start to herniate and cause compression of the nerves, the central canal, or the foramen. And again, here there is an example of a normal, healthy-looking spine, and here there is the compression of the nerve root. As the nerve starts getting compressed, normally the disc herniations are more to the side, and that causes compression of either the exiting or the traversing nerve roots. Discogenic back pain is usually associated with bending forward, lifting heavy objects, coughing, sneezing, because you're basically increasing the pressure inside the disc, and that causes the expansion of the disc material, the nucleus pulposus, against the annulus, which has all the pain fibers, and that causes back pain. Obviously, when the annulus fails and the disc material starts to protrude, then you start to get radicular pain and radiculopathy, which I have mentioned. The nerve roots are normally formed with an anterior component and a posterior component. They join together and they form the nerve root. The spinal cord ends at the level between L1 and L2, so anything below that is the cauda equina. So these nerve roots actually formed at a much higher level, but they come down and they exit at the relevant levels. So that's why when you get a compression in the lumbar spine, you mainly get a low motor neuron kind of picture where you have weakness, flaccid paralysis, absent reflexes. But as you get compression of the spinal cord, it can be more of an upper motor neuron picture where you have brisk reflexes, altered gait, and it can also have a bit of radicular component to it. Normally, the BAS guidelines say that if there is a disc pathology, the natural rate of recovery is between 12 to 15 weeks. Rehabs should be the first line of treatment. Conservative treatment includes manual therapy, CBT, and you would normally refer somebody when there is weakness, and if the weakness is something like they're on the MRC grade 3 or below that, then I think that's a good indication to refer the patient to a specialist. Why does degeneration happen? It's multifactorial, it's genetics, it's what kind of work you do, environment, trauma, inflammatory processes. So initially there is annular tears, internal disruption of the disc, and then you start getting stenosis, arthritis, osteophyte formation. These cause compression of parts of the nerves or in the cauda equina. This also leads to what we call as modic changes. Due to the leak of the disc material into the end plates, you get inflammation in the bone. It's quite important how we talk to our patients. If we tell them that you have got arthritis, a lot of them get quite worried, and you have to explain to them in a way that allays their fears. Explain to them that normal wear and tear is a part of aging, and this can be normal for somebody of their age. So thereby, it's quite important how we convey our message to the patients. It should not get them too worried. So modic changes are when you have the inflammation of the bone. We have 3 types of modic changes. Type 1 is when the inflammation is acute, and then type 2 is a process where the inflammatory process is being replaced by fatty changes, and type 3 is when you have the sclerosis happening. So when we see earlier on these kind of patients, we couldn't do much for them. We would just send them mainly for physical therapy, steroid injections, but now we have other options, and one of the options is what we call as the basivertebral nerve ablation. So here in the vertebral body, we have the basivertebral vein and the nerve. So that nerve branches superiorly and inferiorly, supplying the end plates. So there is an option of trying to ablate the nerve there, and thereby that can help with vertebrogenic back pain. And this is an example of one of my patients where I put a probe inside the bone where the basivertebral nerve is, and using the heat, we burn the nerve. It gives symptomatic relief. It doesn't cure the problem, but it helps with the symptoms. So this is an option that's catching on. A lot of the surgeons are being trained to do this, and we have been also offering this at Fortius. Another case where you have massive disc herniation, where it's compressing the chorda equina. Luckily, this patient didn't have chorda equina syndrome, but had quite severe compression of the chorda equina, and I can't take credit for this. I must give credit to Irfan.
Jack, you might be tell people that's how the disc comes out.
And you can see that's a huge, massive disc that's been taken out by Mr. Malik. And then you can see the delight on the patient's face. This is all done under sedation, so the patient is awake.
I feel okay. A little bit lightheaded when I first came up. That's fine.
Move your toes up and down. Let's see if you can stand up. Let's stay up. Let's stay up. Okay, how do you feel? Nice deep breath in. If you want to. Sleeping on the leg.
Hey!
Feels good?
Yeah, it's good.
Excellent.
Usually I get.
So it's self-explanatory. So the endoscopic surgery, large disc, if you have good patient selection, then you can give them treatment straight away. It's a day case procedure. Patients go home the same day, and they have fantastic results. This man did extremely well. He's very happy for me to share this, and I've had this permission from him. So this is another patient of mine which I have operated upon. So I had large disc at L5S1, did an endoscopic surgery, and postoperatively a significant reduction in the size of the disc. So it does work, and if you have the right patient selection, you do get good results with endoscopic surgery. Coming to the facetal pathology, this is a bit difficult to treat because it's not easy to diagnose. Normally, with facet joint arthritis or facetogenic back pain, you normally will get the symptoms on extension. And the NICE guidelines say do not offer steroid injections, though in our day-to-day practice, a lot of us do offer them because patients come to you, they want something to be done. And so the NICE are guidelines, but you have to obviously cater things to the patient's needs. So you have tried conservative treatment. They have had a visual analog scale score of greater than 5. They have responded to medial branch blocks. In these cases, you can offer them radiofrequency denervation. So this is one of the ways of treating facetogenic back pain based on a streamlined pathway. The facet joint arthritis, as it progresses, can form these cysts, and they can compress the nerve roots. It can cause a grade 1 or grade 2 spondylolisthesis. This is because there is microinstability at that level, and these can be treated surgically, and that's when we get involved and offer the surgery for patients. There's another case. This is a rather unusual solution for facetogenic symptoms with stenosis. So this is a facet joint replacement. So this is not commonly done surgery. It's like it has to be very selective. You have to be very selective about your patients. You have to have a very good MDT on it, and only then can these kind of treatments be offered. This is not NICE approved, but we have had this study done in Southampton, and we had some good results. This is a patient of mine that I'd operated upon. This is 4 weeks postoperatively. As you can see, the patient is doing extremely well.
And lean back if you can. Good, excellent. And if you stand straight again and lean to your side.
Somewhere that way?
The other way. Excellent.
There's another solution. This is I just wanted to give some information upon this. And we have had the study done when I was at Southampton with a 5-year follow-up. So this is an option for where you can offer facet joint replacement for certain patients. Lumbar stenosis is narrowing of the spinal canal due to compression of the nerves. That causes ischemia, neurogenic claudication. It's a combination of disc space loss, osteophytes, hypertrophy, or ligamentum flavum. Not all patients with abnormal MRI scans have symptoms, so we don't treat the scans. We have to treat the patients depending on what they experience. Stenosis symptoms, neurogenic claudication, we need to differentiate it from vascular claudication. Normally with vascular claudication, you have a fixed walking distance. After a certain distance, patients get pain and discomfort. It's not usually relieved with change in posture. With spinal stenosis, you get relief with bending forward. For example, when somebody cycles, they feel better, and that's because you're decompressing the nerve. It's a change in the position. Here, there is this. The MRI scan shows quite narrowing. This is stenotic spine where you have loss of resolution of the nerve roots. You can see the nerve roots, the little dots are the nerves in the back. But here, as you can see, there's complete crowding. And as the stenosis worsens, then you get ischemia of the nerves and thereby the symptoms. Spondylolisthesis is another condition where there's a forward slip of the vertebra one over the other, and we grade it. We have 4 grades on it. Grade 1 is, up to 25%, and grade 4 is 75, up to 75%, and the grade 5 is when there's a complete forward slip of the vertebra. And again, in these kind of conditions, initial treatment is conservative unless they have neurological deficit, they're getting worsening of pain, and then the surgical options are available to treat these conditions. We need to differentiate the type of spondylolisthesis, which could be degenerative or due to a pars defect. Here, as you can see, there's a pars defect, but the other two is mainly because of degenerative changes. They present slightly differently in terms of clinical symptoms, primarily because when you have pars defects, the posterior elements remain where they are, so you don't get much central stenosis. But when you have like a degenerative condition, then the whole thing slips, so you get both foraminal and central stenosis. Examples of the pars defect here, as you can see, the spinal canal is well preserved. You have a wide canal there, so you don't get like central neurogenic symptoms. You mainly get radicular symptoms. But in the degenerative cases, you get narrowing of the canal, and thereby you get neurogenic claudication. Early imaging is not routinely recommended. Basically, you would try and treat them without a surgical or an intervention. You try physiotherapy, cognitive and behavioral approach, and only X-rays should be considered when you're thinking about fractures. In the spine, you have different patterns of fractures, and if one of the risk factors are there, like the female sex, increased age, menopause, oral corticosteroid intake, then you should think about osteoporotic fractures. One of the solutions we have for osteoporotic fractures is a procedure called a balloon kyphoplasty. It reduces and stabilizes the fracture, corrects the deformity, prevents new fractures from happening, and improves the quality of the life straight away. Here's an example of an osteoporotic fracture here. The bone is collapsed at the top here, and this is a keyhole surgery, again done under sedation, where an instrument is put inside the bone, and then we can use different ways of expanding the bone, restoring the height. I tend to use a balloon to get back the height, and then that restores the height and fill it up with bone cement, and patients get immediate pain relief, and they can get back to their normal activities ASAP. Thank you.
Thank you, Ace, for that incredible talk, and thank you for sharing the excellent outcomes that your patients have had following your innovative procedures.